Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about the histologic subtypes of lung cancer. And as the title goes, histologic subtypes. That means without histopathology, you can't use radiology alone to tell the histologic subtype of a particular lung cancer. But there are certain general radiologic features that we can use to give us a clue, but all power lies in the hands of histopathology. That's just by the way. So lung cancer can be thought of as two types: small cell and other histologic subtypes that are non-small cell, such as adenocarcinoma, squamous cell carcinoma, large cell carcinoma. Adenocarcinoma is the most common subtype of lung cancer. It is related to smoking, but to a less degree than squamous cell. Cavitation can also occur, but this is also less commonly seen compared to squamous cell carcinoma. The typical radiologic presentation of adenocarcinoma include a solitary nodule with spiculated margins due to surrounding reactive fibrosis. You can also have pure ground glass nodule or a subsolid nodule. And this subsolid nodule could be mixed ground glass and solid. You can also have purely consolidative adenocarcinoma, which may present as diffuse ground glass opacities or diffuse consolidation resembling airspace disease. So in these images, the first one is an axial CT and it shows a solid nodule with air bronchograms and a more peripheral ground glass nodule. And these two different nodules with different characteristics were both shown to be adenocarcinoma subtypes on histopathology. Then this image is an axial contrast enhanced CT and it shows a right lower lobe consolidative opacity with air bronchograms. And adenocarcinoma is an important differential consideration for this. Of course, this was also proven to be adenocarcinoma, but it could very well pass for a lobar pneumonia in the absence of histopathologic diagnosis. You can also rule in cancer if after antibiotic treatment, this consolidative process still persists. Now, lung adenocarcinoma is primarily categorized on the basis of histopathologic evaluation. So if you just make a diagnosis of adenocarcinoma, that's fine. But I think it's important to also know some of the subtypes of adenocarcinoma histologically, because there are some radiologic correlates. So with regards to the radiologic correlates of these histologic subtypes, the pre-invasive with its different subtypes, the minimally invasive, and the lipidic growth pattern form of the invasive histologic subtype of adenocarcinoma will all show subsolid and ground glass nodules, while all the other subtypes of invasive adenocarcinoma will show solid nodules. This is because these involve the airway and can partially cause airway disease. Lipidic growth is a spread of malignant cells using the alveolar walls as a scaffold. And since it's using the alveolar walls as a scaffold, it means you can have partial airspace filling leading to ground glass opacification. There's another form of growth pattern, which is the hyalic growth, HILIC, and that is the opposite of lipidic growth. In hyalic growth, it demonstrates cancer growth by invasion and destruction of the lung parenchyma, and that one would lead to solid nodules, not subsolid nodules. So with this information, we have an irregularly shaped, somewhat spiculated mass identified in the lingular segment of the left upper lobe. And centrally within this mass are multiple focal radiolucencies and some areas of ground glass attenuation. Now, this was histologically proven to be a lipidic form of invasive adenocarcinoma. Now, squamous cell carcinoma is slightly less common today than adenocarcinoma and most commonly presents as a spiculated nodule, just like adenocarcinoma. However, it can also present as an endobronchial or hilar lesion. The majority of squamous cell carcinomas arise centrally from main lobar or segmental bronchi, where the tumor tends to cause symptoms early due to bronchial obstruction. Now, common radiographic findings are lobar atelectasis, mucoid impaction, consolidation, and bronchiectasis. Now, it's important to note that squamous cell carcinoma has the propensity to cavitate. The way I try to understand squamous cell carcinoma is just putting at the back of my mind that it is highly associated with smoking. Now, what does smoking do? When you smoke, the smoke goes through your airway, through your trachea, through your bronchi, constantly irritating it. And so, because of the constant irritation, your nice, juicy pseudocolumnar epithelia that lines the airway differentiates into squamous cells, which rather line places that are prone to constant trauma, like the skin, the mouth, the vagina. So it's a more central disease within the airways compared to adenocarcinoma. Now, in this axial CT, we show the classic spiculated cavitary lesion, which was shown at pathology to be squamous cell carcinoma. Now, small cell carcinoma is the third most common lung cancer cell type after adenocarcinoma. So you have adenocarcinoma, then you have squamous cell carcinoma, and then small cell carcinoma. Neoplastic cells are of neuroendocrine origin when it comes to small cell carcinoma, and they are associated with various paraneoplastic syndromes. Small cell carcinoma is strongly associated with smoking. Small cell usually presents as mediastinal or hilar lymphadenopathy, typically presenting as a large hilar or perihilar mass. Now, the involvement of the superior vena cava because of this hilar mass compressing on it may cause SVC syndrome. Now, small cell rarely presents as a solitary pulmonary nodule, and the primary tumor is usually not identified. So how I remember this, that's not necessarily true, but it's just a memory tool. Small cell is so small that it can't be seen. So the primary is very hard to find, but what you would usually see are hilar and perihilar masses, likely lymphadenopathy. For staging purposes, small cell is divided into the limited stage, which involves one hemithorax, and the extensive stage disease. The limited stage is treated with chemoradiation, and then the extensive stage disease is treated with chemotherapy alone. So with these images that shows small cell carcinoma, of course histopathology proven, this chest radiograph shows a right paratracheal opacity, which corresponds to the mediastinal and hilar lymphadenopathy on CT. The lesion encases but does not significantly narrow the involved bronchi and the main pulmonary arteries. Now to large cell carcinoma. Large cell carcinoma often occurs in the lung periphery, where it presents as a large solid mass with irregular margins. Focal necrosis can also be present. Histologically, large cell carcinoma is characterized by large nuclei and nucleoli with a moderate amount of cytoplasm, hence the name large cell. Large cell carcinoma can have rapid growth and early metastasis, and thus an overall poor prognosis. So in this image, it shows a right upper lobe apical mass invading the adjacent chest wall. The surrounding lung parenchyma shows interstitial fibrosis consistent with chemotherapy and radiation. Now, there are also prominent paraseptal emphysema, and some subpleural blebs and bulli are also seen. So this was a case of large cell carcinoma. So to summarize, lung cancer can be thought of as two types: small cell and non-small cell. And under the non-small cells, we have adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. You can only be 100% sure of these histologic subtypes after histopathology. However, some radiologic features can point you towards a particular histologic subtype. I hope, as usual, you enjoyed this and you found value from these videos. If you did, share with someone you think would also need it. Leave a comment, like the video, subscribe. Our next topic is going to be carcinoid tumor and pulmonary lymphoma. I'll catch you in the next video.